committee for the CDC Clinical Trials Group and a member of the SCI Breast Steering Committee and the Report B Advisory Group. She is also a Common Scholar and a member of the Scientific Advisory Council for Common. She sits on the International Advisory Board of the Lancet. So we had some issues with Lancet, so we can talk with her. The oncologist, the clinical breast cancer. She published over 250 publications. She was a recipient of a YWCA Women Distinction Award in 2003 and an award from the Canadian Friends of the University. And what is very important is that she loves Israel, and she is a personal friend of many of us. So Dr. Gelmon, please.
Thank you, Renat. Very nice to be here. So we're running a few minutes late. Hopefully I won't go over time. I'm charged with talking about cancer therapy in the 21st century. Is cardiotoxicity still an issue, particularly for breast cancer? So these are my conflicts of interest. So I think there are a number of cardio-oncology issues, and I'm going to not mean to sound cynical, but I think there are some things that we need to bring up. First of all, do we need oncologists with knowledge in cardiac issues or cardiologists with knowledge in oncology issues? There is some interesting evidence recently from Mira Levy from Vanderbilt that is just in publication showing that multidisciplinary care improves outcomes for patients. And how you define multidisciplinary care can be different ways, but I do think that this is interesting data. Doesn't suggest that we are duplicating care. I think this is something we have to rail against, because what we don't want is all of our patients seeing both cardiologists, oncologists, other specialists in duplication. Not only is it resource intensive, but for our patients, they become medical cripples because they're going from one appointment to another. So I think what we have to work for is that we're not increasing costs or duplicating care. We're not overemphasizing toxicities that have no basis in common sense, but that what we are doing is providing our patients with more comprehensive care that is better for them. And that's what we really have to be talking about. I was very interested in the cardio-oncology talk on pregnancy today, because many of us in this room doing a study called Positive, looking at pregnancy after breast cancer care in patients. And I think the cardiac issues have been very understated in that trial. So I think there's places where we can heighten information, where we can improve patient care, where we can do more for our patients. What we have to watch is that we're not just writing recipes and duplicating care, because that's too easy. So this is basically a cartoon sort of to that effect, that what we don't want to be doing is selling our patients a bill of goods, that we're really giving them something better without doing that. When we look at the spectrum of treatment for the patient, we want to support the patient through the cancer journey. Journey being a bad word for many people, but basically we have talked already and touched on it in this meeting. We're going to be talking all the way from prevention to quality of life. And all the way through that, what's been important and come on to that is that patient-related outcomes are our prime concern, both in clinical trials and in clinical practice. So that's where the balance and where cardio-oncology can really make a difference in really looking at some patient-related outcomes and what's important here. One of the things we always have to talk about is measuring success. So what's success to the oncologist? If you just look dryly at it, what we look at is progression-free survival. Those are our metrics, and we often can get too focused on that. When we ask the patient, it's a decrease in symptoms, it's improvement in quality of life, it's improved survival, but good quality of care. Nobody wants survival without good quality of care. Treatment with fewer side effects, and people want hope and continued options for treatment, and they don't want crook necks from sitting in the front row. It's hard to see from that front row. When we talk about success to the cardiologist, I think we're looking at giving little or no cardiotoxicity and integrating that with our cancer care. I want to remind you about the algorithms in clinical care for the oncologist. We look at early cancer, and there risk versus response is most important in the curative setting. We look at advanced cancer, and we look at symptoms, survival, and quality of life. And then there's supportive care, where many of these cardiotoxicity issues are probably less relevant, but it's still relevant to the patient. So let's just focus for a few minutes on early breast cancer. It's curable in many cases, still not in all of our cases, but increasingly this is a curative situation. So therefore, the risks of the treatment must not outweigh the benefit. And this has been a real focus of withdrawing therapy where we're over-treating and knowing how to treat specifically. Treatments over the years have evolved to include toxicity and health-related outcomes as paramount to consider. And we have to remember that in early, we're talking about risk of distant relapse that we often focus on because obviously it's distant relapse that can kill the patient, but we also are looking at contralateral disease and local relapse. We have to remember and be honest as medical oncologists or radiation oncologists that many of our patients are cured by surgery alone, and yet still in 2017 we're not skilled enough to recognize that, and any treatments must be carefully considered if you think that the majority of our patients with low-risk cancer are cured with surgery alone. In advanced cancer, we're looking at good quality of life, not just prolongation, issues of toxicity versus benefit, and treatments must be effective and tolerable, providing a survival benefit if possible, but mainly good quality of life. And cardiotoxic issues must be manageable. This is particularly important here. In the curable setting, we don't want to take a 32-year-old woman, give her intensive curative treatment, and end up with a cardiac cripple at 50. On the other hand, we don't want to destroy someone's last years with having significant toxicity. So it's both sides are important. Now, one of the things that's important is understanding the numbers of populations in breast cancer. And this slide is a simplistic slide, but it reminds me to bring up that there are really two issues. We focus on tumor, different kinds of tumor, and whether we're talking about AML or lung cancer or breast cancer or colorectal cancer now, we're increasingly dividing them into smaller and smaller subgroups of tumors. We also have to think of the patient. What we realize is that the pharmacogenomics of patients vary, and in some societies it's less than in others, but certainly most of us have different pharmacogenomics from the others. So it's both looking at the populations differently in terms of the host, their pharmacogenomics, and increasingly their immune system, which relates to that, versus the tumor, which is different. So understanding those populations. Since 2000, we've known very clearly that there are different populations of breast cancer. We knew that before with ER positive, ER negative, but this really was the work that made us now start thinking about the basal, the luminal A, the luminal B, the HER2 enriched. And since that time, there have been a number of other classifications, including 15 classifications and the 10 classifications that I often look at from Sam Aparicio and others. This is work that one of my fellows from Brazil did looking at patterns of breast cancer recurrence in British Columbia. And the cohort on your left, cohort 1, is the cohort that was similar to the cohort that Swanee had published in 1996, going from the late 80s to their mid-90s, where we didn't use Herceptin, where we didn't use AIs, where we didn't use taxanes. What you can see clearly there is that there's a big peak, the yellow peak, which is the HER2 positive ER negatives. There's also a peak of the HER2 positives and of the triple negatives with an early relapse. And the blue line, which is the ER positive HER2 negative, showing a continued risk of relapse up past 5 years. In cohort 2, when we'd introduced these new therapies, the peaks are smaller, but there are still peaks. So the patterns are still the same, even though we've improved outcomes. What's important to note is that with ER-negative breast cancers, they cross at about 4 years, and their risk of distant relapse is very low, but ER-positive cancers continue to have a long relapse pattern. This is just bragging data that was published in The Lancet, showing that British Columbia, where I'm from and Renat and Moshe are partly from, has very good outcomes for breast cancer along with other countries. So this is important that we see that our improvements have shown a basis in terms of better outcomes in geographical places. Now, what are the current therapies for breast cancer with cardiac implications? These are really divided up, and this is simplistic, but basically when we're looking at the hormone positive, HER2 negative early breast cancer in the pink square, We've got aromatase inhibitors and tamoxifen, which I'll talk about. We've got anthracyclines and taxanes. Capecitabine may be coming in there more with the recent CREATE-X data being published in the New England Journal. We've got radiation. And this is just a simple list of things that are currently in use. With the HER2-positive breast cancers, we've got the anthracyclines, trastuzumab, pertuzumab, lopatinib and neratinib in the TKIs, taxanes and radiation. With triple-negative, we've got some of the same drugs. Capecitabine may be used more, and there's a whole question of the immune agents coming in. And with advanced breast cancers, we've got a number of targeted agents, such as the mTOR or PI3 kinase inhibitors, the CDK4/6 inhibitors, anti-angiogenic agents, and the immune agents that are all coming in. So there's a number of different drugs that we have to just consider. And the treatments that we give are really based on the molecular markers in a simplistic way right now, hopefully getting more complex. The promise of having everyone get their genomic testing done and their treatment according to that isn't quite there yet. And in fact, in breast cancer, we're lagging behind some other tumor types in sorting this out. I think that the number of genomic tests that have been done and the amount of benefit from them is probably minimal when you look at large sequencing panels, but certainly specific marker panels have been very, very successful, particularly in tumors such as lung cancer. This is just old data from the Lancet, from the early breast cancer trialists, just showing the initial benefit of chemotherapy versus no chemotherapy in early breast cancer. And this shows a panel for the anthracyclines and a panel for the non-anthracyclines, showing a decrease in recurrence and an improvement in mortality for both of the groups. So basically, this is what really started us doing adjuvant chemotherapy so much. The first discussion of adjuvant chemotherapy was presented at ASCO in 1978, but it was really the early clinical trialists that got everything working in a bigger way. When you look at adding taxanes plus anthracyclines, this was published in 2011. It did show a benefit for the addition of taxanes. Now, taxanes, we're going to talk very briefly about them as cardiotoxic. We often talk about them as an addition, but in reality, the toxicity that they cause, particularly neurotoxicity, is quite profound for our patients. In early breast cancer, what we're really looking at now is the risk of cancer recurrence versus responsiveness, and balancing with toxicity. So the toxicity includes cardiotoxicity, but the toxicity includes any toxicity. Increasingly, we're understanding that it's not just risk, but responsiveness. And with the idea about responsiveness, we have withdrawn chemotherapy from very many patients because we realize that although they may have nodes positive or have a high-risk cancer, their cancer is not going to respond, at least to our current day chemotherapies, and we have to do better. So what has this resulted in? Decreasing use of chemotherapy in ER-positive patients, decreasing use of anthracyclines. That's variable around the world. It matters what other drugs are available. It matters how people interpret the data. But certainly for low-risk cancers, there's a marked decrease in use of anthracyclines. Sorry, cardiologists, we'll put you out of a little business. And there's also increasing use of AIs, aromatase inhibitors, including extended use of aromatase inhibitors, despite the fact that since San Antonio there's been controversy about their benefit. There's the use of tests to define who can be spared chemotherapy, and this includes the Oncotype recurrence score, the PAM50, MammaPrint, and other tests. What we have to be honest about is although we have a good idea about the low risk, we still don't have a good idea about who we can spare chemotherapy for in the intermediate group. The MINDAX study gave us some of that data, but the TAILOR-X study still hasn't been reported. And so often with the intermediate group, although we think we can maybe get away without chemotherapy, we don't have the randomized data yet to prove that. This is just data from the Austrian study where they looked at using the PAM50, and the red line is the luminal A, the blue line the luminal B. One can see very clearly that there's a difference in outcome for the luminal A versus the luminal B. It's hard to improve that luminal A outcome. Those are patients that definitely do not need chemotherapy if we can recognize them. Not all Patients who look luminal A do well. There's a translocation that you can't recognize by just looking histologically, and those are some of our luminal A patients who don't do well. We'll have to figure out how to deal with that later. But the majority of luminal A patients do well. However, they have a continued long-term risk of relapse of about 1 to 2% per year. That's likely not going to be improved by chemotherapy. The luminal B are more complicated. They have a less good outcome. We do believe that many of them do respond to chemotherapy, but again, this is a group where we need targeted agents and really understanding which targeted agents are going to improve whose outcome. So risk-benefit ratio must be considered. Is there a survival benefit? Is one option less toxic? Is the follow-up long enough? And this is what we often fall down in, is not having long enough follow-up to conclude that we can eliminate drugs that are possibly toxic and not necessary. And I would add that long enough follow-up for cardiac endpoints is also probably not long enough, because many of our studies and looking at cardiac endpoints at 5 years, which might not be long enough when you're looking at long-term outcomes. What about risk stratification? And I think the other question is, are all cardiotoxic drugs created equal? So we've got a lot of missing data. Can we predict who will benefit and who will not? And who can we drop certain drugs in and who not? This is just a breast cancer primer, chemotherapy primer. And just to remind you that there are a number of anthracycline-based chemotherapy agents. There's anthracycline-free listed there. There are also combinations that include both anthracyclines and taxanes, and some of these are being used less frequently, others are continuing to be used. The dose-dense AC paclitaxel is a very, very common regimen around the world, as is the TAC-FEC-D. I don't have to remind this audience that when we're talking about cardiotoxicity, we're talking about a variety of different things, not just decreases in left ejection fraction. Anthracycline-induced cardiotoxicity is old news, obviously. Since 1967, it's been recognized and can be fatal. And we have to remember that there's both the acute arrhythmias that can happen shortly into the infusion, as well as the long-term cardiomyopathy. And that's what we really are most concerned about. It can be especially severe in children. And in severe cases, there is a high mortality risk. The correlation between cumulative doxorubicin dosage and incidence of congestive heart failure has been known for a while, and increasingly there's attempts to try to define that early, and I see that over the next day and a half there are a number of people talking about this, so I won't go into it, but suffice it to say that people have been trying to look for blood monitors such as troponin, people have looked at biopsy, people have looked at a variety of different imaging techniques to try to define that change in cardiac function early, as in the clinic, particularly before we had cardio-oncology clinics, most of the cardiac damage we recognized in oncology was very late. It was only when our patients came in with effusions and we realized they weren't malignant effusions that anyone realized that we were doing cardiac damage. So I think this whole area of trying to understand cardiotoxicity early is important, and I know there's a number of speakers who are going to go into this. What's also interesting is this data from 2000 New England Journal of Medicine paper looking at causes and long-term survival and showing a very poor survival for those persons who were thought to have doxorubicin cardiomyopathy. And this again is from 2000, where the recognition was usually in the clinic when people came in gasping for breath, and many people assumed it was disease recurrence rather than toxicity. What's important to know with anthracycline-induced cardiotoxicity is, although high cumulative dose is one of the most important factors, there are patients who have a risk with a very low dose, and those individuals might not be recognizable immediately as being susceptible. This again goes to pharmacogenomics, where we have all the patients with the same diagnosis, but we have different patients who have a different risk of having an acute drug reaction. I'm fortunate to work in a place where Bruce Carlton and Michael Hayden, well, Michael Hayden's now in Israel, but Bruce Carlton is still in Vancouver, and they've got a pharmacogenomics network that mainly deals with childhood cancers, but we've been looking at toxicity in adults as well. We've recently published a paper on cisplatin ototoxicity in adults, in testicular and ovarian cancer patients, as well as some lung. And we're just trying to get a paper in press looking at some SNPs that seem particular for adults. Of interest, these are the variants that were shown as genetic markers predictive for anthracycline cardiotoxicity in children, and the ones in adults are different SNPs, which is interesting. They've developed a pediatric anthracycline cardiotoxicity risk prediction tool, and I would hope that the next step is adult patients. We've been collecting blood on patients and have about 1,400 patients that we've analyzed for SNPs to look for these predictives. Will they come into practice? I think it's a question, and I think the whole area of pharmacogenomics, I'd like to see more and more of those come into practice, but it'll take some time. It certainly would be of interest in terms of looking at our host and our toxicity. So getting back to cancer treatment modalities, anthracyclines we've talked about, and we've heard some very nice studies about myocytes as a primary or direct toxicity. The time to presentation can be weeks or decades. There have been a variety of strategies that have been used, including prolonged infusion. There have been some cardioprotectants that have been used, but in the study, a randomized study of deroxazone versus free doxorubicin, there was some concerns about outcome. Liposomal formulations have been used, and increasingly people have looked at beta blockers or ACE inhibitors as protectants. It is dose dependent, often subclinical damage, and as I said, may go undetected for long periods. We'll talk for a little bit of time around trastuzumab, which came along really as the type 2 cardio-damaging agent with contractile elements. It usually presents in terms of weeks. It's often reversible, it appears. ACE inhibitors, beta blockers can be used. And it does appear to be more evident when given with certain drugs such as anthracyclines or for patients who have underlying cardiac damage. So we've heard elegant talks about myocytes, and I know we're going to hear more, so I won't go through it, but suffice it to say that first question is it a healthy myocyte population? I think that's what we heard in the last talk, or the second last talk, that many of these patients come in and don't have healthy myocyte populations to start with, then get the anthracycline with damage, and then have a vulnerable myocyte. There have been a number of adjuvant trastuzumab trials, and this summarizes all of those trials with different durations of trastuzumab. One of the problems with all these trials is they defined cardiotoxicity differently. So some of them just looked at declines in left ventricular ejection fraction, some of them looked at arrhythmias, some of them looked at congestive heart failure, some of them had short follow-up, others had longer follow-up. So it's hard to really compare them. But what's important here is the number of deaths are low, there was reversibility reported, the incidence of left ventricular dysfunction, you can see, goes all the way from 4.1% to 18.6%, and there's also differences in scheduling. Congestive heart failure incidence is variable as well. This is just a graph from a publication in 2012 looking at longer follow-up, and this is age greater than 75. And as you hear, we're getting increasing numbers of patients who are older, and I think what's quite amazing is that risk at age greater than 75 over the years. So I think, again, we've been looking at short-term follow-up, we've been looking at patients who are eligible for clinical trials. Many of our patients we treat in the clinic would not be eligible for a clinical trial, are older, and may have more significant problems with the standard treatment. This is the cardiac safety in the HERA trial. There have also now been trials reported of 6 months. This was looking at 1 year versus 2 years, and showing that although the fatal events were low, there were increasing secondary cardiac events that were increased, particularly with 2 years of treatment. And I think that's important to note. So cardiomyopathy is the main toxicity with trastuzumab. There was a Cochrane analysis of adjuvant trastuzumab that looked at 8 randomized trials, over 11,000 women. And what was important was that it was 5.11 times higher, the congestive heart failure rate for trastuzumab, compared to the other. Those are the absolute numbers, 2.5% versus 0.4%. And the left ventricular ejection fraction decline was 11.2% versus 5.6%. We can say how many of those were clinically significant. And I think that's a question. But one of the problems, as I said, is short-term follow-up versus long-term follow-up. So short-term declines may not be clinically significant at the time, but 20 or 30 or 40 years later certainly may have significance. Anthracyclines augment the risk of cardiac damage in this analysis. We've got a new kid on the block. Pertuzumab is another antibody. It works differently than trastuzumab. It inhibits HER2 heterodimerization, and the two together work better than one alone. Pertuzumab on its own has very minimal activity. At the ASCO meeting last week, we had final presentation of the Affinity trial, which was the first randomized trial looking at adding pertuzumab to trastuzumab and chemo in early breast cancer. So we're talking about early breast cancer, curable women. What does adding another antibody do? And what does another antibody do to cardiac function? I'm not going to give all the outcome data because people have seen that. It showed a modest improvement, particularly in the node positives, and very minimal in the node negatives. So it will come in probably to use in the node positives in anybody who can afford it. And in countries like Canada and Israel, there might be spotty use of it. But I think pertuzumab is important. This is the primary cardiac endpoint. And again, these were patients who had to have normal left ventricular ejection fractions to get in, who had regular cardiac monitoring. If you look at heart failure drop by the New York Heart Association, you can see that it was slightly more in the pertuzumab arm compared to the placebo, 0.6 versus 0.2. You can see cardiac deaths were exactly the same and recovered according to the left ventricular ejection fraction. They did recover in the pertuzumab arm, suggesting that it was a transient decrease. When one looked at secondary endpoints, there was really no difference in asymptomatic or mildly symptomatic drops in left ventricular ejection fraction, suggesting that the addition of pertuzumab did not increase cardiotoxicity, although it did increase diarrhea. Here you can see primary cardiac event. There were an increase in number at 15 with those that had anthracyclines. This is a busy slide, but the first two bars are those people who had an anthracycline-backed chemo. The last two bars are the non-anthracyclines. So it was really in the anthracycline plus pertuzumab plus trastuzumab where we saw the events. But again, cardiac deaths were not different between the two arms, both of them occurring in the anthracycline-based arms. Secondary cardiac events, however, were markedly increased in the anthracycline arms compared to the non, again suggesting that maybe we can drop the anthracyclines, which has been suggested a number of times by other studies. So the pertuzumab per se didn't look like it increased, but the anthracycline compared to the non-anthracycline certainly looked like it had more cardiac events. I think this is important in terms of being contemporary. All the things like exercise have come in since the initial trastuzumab studies. We've been more aware of BMI. We've been more aware of maybe our patients taking aspirin and other things. So I think what's important about these results is really a contemporary look at what the risk of cardiac toxicity is in a group of patients getting anthracyclines, trastuzumab, and pertuzumab. Heart failure, you can see New York Heart Association 3 or 4 was about 2.5%, 2.3% in the anthracycline arms, and 0.8% in the non-anthracycline arms. This was also presented at ASCO and was a study without any anthracyclines, and what one can see here is that the cardiac events were markedly lower, and I don't know what's happened to some of that writing there, but basically 29% with the anthracyclines versus 17% without the anthracyclines, and the cardiac events were mainly, except for the myocardial infarction, in the anthracycline. So clinically, acute cardiomyopathy is difficult to gauge as studies measure left ventricular early, B31 and 9831, you can see the results there, and I think this is of concern that it's... So what's the real story? I think it's a real but small risk of cardiotoxicity, more with anthracyclines and anti-HER2 than non-anthracyclines. TKIs have less cardiotoxicity. We've known that there's an increased risk with pre-existing cardiotoxicity, a high BMI, hypertension in the elderly. However, in most of our patients we're treating, the risk of HER2 recurrence is greater than the cardiotoxicity, so we have to balance that. I think there's increasing use of non-anthracyclines. I think it's important to continue to monitor heart function in early disease. Personally, when it's advanced disease, I don't think there's any reason to monitor unless they've got clinical concerns or you're changing treatment, because if you've got effective anti-HER2 therapy in the advanced setting, you don't want to stop that. So clinical is important. Just to go through a few things, radiation therapy we know can cause problems, and what's of importance is in all of the studies of trastuzumab or pertuzumab, anthracyclines, there's been no increased damage for those patients with left breast cancers who have had radiation. So I think radiation on its own has cardiotoxicity, particularly vessel damage, but it doesn't seem to augment, at least in the studies we have, the other damage. As I said, we've got short follow-up, however, and radiation damage often can be quite late. Not going to go through all of this for time. I think there's other anti-cancer treatments associated with ischemia, and the one I want to highlight here is capecitabine, because we're increasingly using capecitabine, and we may use it more in triple negatives in particular. For any of us who have seen ischemia with capecitabine, it's frightening, and people can get quite ill, and you don't want to re-challenge, because I've tried re-challenging and it happens again. So I think it's something to be aware of with our patients. We usually don't remember it, but it's something to be aware of. I think paclitaxel and docetaxel initially were thought to cause bradycardia. Well, I'm done. But they can cause ischemia as well. I want to spend a few moments, even though I'm running late, looking at hormonal treatment, because increasingly I think we underestimate this, and we're giving more and more long-term hormonal therapy. We've had issues of thrombosis and PE with tamoxifen, but with aromatase inhibitors, there's increase in cardiovascular events, which include arrhythmias, valvular dysfunction, and pericarditis. It's often difficult to risk out from the underlying causes in postmenopausal women, and there also are cholesterol increases. So this might be an issue with long-term administration. This was a poster at ASCO looking at extended aromatase inhibitor and a meta-analysis from the group in Toronto. And what you can see is cardiovascular disease. The number needed to harm was 122, so there was an increased risk in cardiovascular disease with extended aromatase inhibitor toxicity. This is data from my group at the NCIC looking at death from MA17, which is extended adjuvant. And for patients who had other risk factors, the red is cardiovascular. So patients with cardiovascular risks did have an increase in death from cardiovascular risk compared to other causes. And this is MA27, which was looking at aromatase inhibitors. So there is some toxicity there, and we just have to be aware of our patients. This is the JAMA Oncology 2016, where they say that there's no elevated risk, but I'm not sure I totally believe that, as I think there's some newer evidence to suggest there might be. And statins are talking about to mitigate the effect. Just to finish up, CDK4/6 inhibitors, there are 3 now, 2 on the market in the US, and ribociclib will likely be on the market other places. In the ribociclib studies, they insisted on doing ECG monitoring, and they did show QTc changes. So in the package insert, you need to do ECGs in those patients. Is this drug different than the other CDK inhibitors, or did the trial just look for something different? My guess is the trial just looked for something different. We have to balance what these QTc prolongations really mean, but I think it's important because we don't standardly do that in hormone-positive advanced cancer. With mTOR inhibition, we have the results from the Bolero, and we know that cardiotoxicities can occur with mTOR with increased expression of hypoxyl inducible factor, with hyperglycemia and metabolic syndromes, so we might see cardiac concerns. With immunotherapy, and you're going to hear about this tomorrow, which is increasingly being used, we do know there's myocardial fibrosis and pericarditis, and there can be a cardiomyopathy and acute heart failure. So again, with these agents, we have to be aware of these concerns. So with therapeutics and cardiotoxicity, there's still a concern: QTc prolongation, metabolic syndromes, effect on the myocyte, and endocrinopathies have to be considered. Finally, I want to finish by just adding in a couple things that, as you heard right from the beginning, Cancer is a bigger killer than heart disease. Our patients are getting more elderly. The elderly are often underrepresented in clinical trials, yet these are the patients we're treating. So in terms of cardiotoxicity, we have to be very aware of who our patient population is. Exercise and cardiotoxicity has been touched on, and I had a PhD student, Amy Kirkham, who just did an acute exercise program with patients getting anthracyclines and showed that acute exercise could protect the heart. This is in press. And other issues we need to understand are the insulin pathway. MA32 is randomizing patients to metformin. In the triple negative, it did not show to be effective, and it's been dropped, but we're waiting. And Renat has just published something in the Annals of Oncology looking at BMI after diagnosis of breast cancer and not showing an impact on outcome, which I think changes the way we think about things. Still doesn't mean we should be gaining weight, but I think it does change how we think about things. And this is one of the slides looking at MA27 and MA14. So in summary, the toxicity of therapy must be balanced with efficacy and risk. For low-risk women needing chemotherapy, the risk of cardiotoxicity is really paramount. For women with comorbidities, the risk of treatment may outweigh the benefit, and as we get more elderly patients, we have to look at that. Hopefully, pharmacogenomics will help us, and we need better predictors, which we're going to be talking about in the next 2 days, imaging, genomic markers, other markers. I think cardiologists and oncologists determining what's really of clinical concern and what is not is important. My pharmacist is always concerned about the QTc prolongation. My cardiologist and I usually aren't. I think working together for the individual patient is important and not doing a recipe or formula. And common sense approach, balancing risk, and we need more research. So thank you for your attention, and I'm sorry I've gone over time.